Welcome to Module 4. This is the last module in this course. Much like the other modules, this is going to start with ATI concepts and then pick up on the Marquise and Houston details at the end. I've tried to hit the highlights. Again, I'm going to try to focus on key concepts that I want you to drill down on and spend a little bit of extra time for. Be sure that you are reading the assigned reading as it's provided to you, and then take notes as you move through the topics this week. They appear somewhat scattered. Again, I think that's the challenge of trying to follow the ATI blueprint and then tucking in some important elements from your textbook. So let's get rolling. The first thing I want to talk about is incident reporting. This is something we've talked about in an earlier module. It's something that I'm sure you've covered in your med-surg courses. Just a reminder, when there has been an event at work that is not expected and harms a patient or potentially harms a patient, we're responsible for documenting those incidents, and we want to make sure that the person closest to the incident is the one completing it, that it's timely, so it's done at as close to the time of the event as possible. We want to make sure that we don't reference the incident report in the medical record, nor do we put a copy of it in the medical record. That document is not discoverable during a lawsuit unless we write in our nursing notes that we have completed an incident report and have sent it to the manager. The minute we mention its existence, then they can subpoena it. So we want to make sure that we not only don't put it in the medical record, but we don't mention it. We want to make sure that the incident report is just the facts. We want objective data only. We don't want to put subjective thoughts about it, how you felt about the experience, just the things that you observed and just the things that were done. And the last piece we want to make sure to include in incident reporting is how the incident was managed, who was notified, when they were notified, and what the steps were taken to provide care or prevent further injury to the people involved. The next concept I want to talk about just briefly is disaster planning. This should be a component of your community health course, maybe in your fundamentals, but definitely community health. I want to just touch on a few key concepts when we think about the nurse's role in disaster management. The first thing we want to think about is mass casualty. I guess maybe I should rephrase that. We don't really want to think about it, but it is an element that, depending on your service area, you could be dealing with. The key to mass casualty that I want you to be thoughtful about is how triage occurs. When we go into an emergency room setting, when there are, competing patient priorities, we normally prioritize based on level of acuity. Mass casualty doesn't work that way. Mass casualty uses a utilitarianism type of approach. The idea with mass casualty triage is that you triage according to who is most likely to survive. So you make the decision of who you care for first based on who is most likely to survive the incident. So when we think about the ethical approach to that, we're thinking about the ethical principle of utility. What that means is that we're looking at finite resources and how we can best serve the people involved totally based on the outcome. And our outcome in a mass casualty is survival or death. So be mindful that the triage process is different. Disaster planning, you've got internal emergencies, and there's a few examples there. External emergencies, you can have a internal emergency that's a fire, and you can have an external emergency that is a fire. It really does depend on where the incident is located. So think about if you're asked, what type of emergency is this, just consider where did the emergency originate from. The important thing with either emergencies is to have readiness protocols in place. So we want protocols and policies that guide, if this thing happens, then this is how we respond. And we need to have a system in place that drives those responses. So is there a response team? Is there an administrator? Is there an external person that we call when something happens? That's all going to be covered under your protocols and policies. But to be ready for an emergency, to disaster plan, we need to have plans in place. We need to not be trying to figure out how to respond to an emergency on the fly in the middle of a crisis. So we want to be thoughtful about those readiness steps that need to be in place. Another comment about types of emergencies. We've talked about most of these. Fires we've talked about. With severe thunderstorms, you're really looking at power and safety, loss of power, and then the safety of anyone involved in managing the thunderstorm. Biological events, chemical events, hazardous material, and radiological incidents. You can read through those within your ATI book. The big thing with all of those is to first take measures to protect yourself and avoid contact. You're going to contain the risk if at all possible. You're going to protect patients, and you're going to follow policy and procedure. As you're going through all of those things, make sure you're notifying the correct response team. We just talked about disaster planning, and some of these can be disasters, and we need to make sure that we're notifying people according to protocol. But those 4 types of incidents have those common elements involved. And the last one is a bomb threat. And normally what we're dealing with is a threat, not an actual bomb. In the event that you have a threat, you want to remain calm and you want to gather details to as much of an extent as possible. If there is an actual bomb, you're going to follow your protocols that are in place and do what you can to protect yourself and then the patients. Switching topics, let's talk about change for a few minutes. Change is tough, and I think if you think about your own experience with change, how do you deal with change in your own world? Do you feel invigorated by change? Does it excite you, or does it absolutely stress you? I'm someone that deals pretty well with change, but I'm married to someone who does not like change. One of our most interesting marital discussions was over moving the Christmas tree. It had been in the same corner for 10 years, and I got this exciting new idea to think that I was going to put it across the room, and he was in a full-blown panic over me moving the Christmas tree. So clearly we have very different responses to change, and the Christmas tree did get moved, and he started breathing and managing it a little bit better. But know what your response to change is. And if you're not great with change, that's okay. Just know that you're not great with change and partner with someone who nudges you along towards change. I like this picture here. It reminds me how it really is a short trip from being excited by change and moving through change to really being torn apart. So it's how we respond to change that helps drive the outcome. The people that drive change within organizations, we call them change agents, and change agents are persons skilled in theory and the skill of implementing a planned change. I want to remind you that change should never be attempted unless the change agent, who the person's driving the change, can make the commitment to be available throughout the process. They shouldn't get change moving and then disappear. And we'll talk about the steps of change in just a moment. Change agents need to be patient, and they need to be open to new ideas. They need to be super flexible. During refreezing, which is a step of the change process we'll talk about in a moment, it can be complex. It can be really stressful, and it's important that the change agent remain present and that they're available to make sure that the desired outcome is achieved. The qualities here on your screen are general qualities of a change agent. When we think about the function of change, there are leadership functions and then there are manager functions. I feel like what's on our screen with visionary and risk taker and flexible, communication, creative, sensitive, and current really lend themselves to describing a leader. The other piece of being a change agent leader is that the leader needs to be flexible in their goal setting. They're going to have a big picture of things. So the leader needs to be flexible in the goals based on the team or the stakeholders' involvement and preferences. There's some ways that they need to set an end point, but maybe how they get there or the timeline, trying to give as much flexibility to accommodate the stress, the fear, the anxiety from the folks that are changing it. So a leader does have that responsibility of driving the change through goal setting, but remembering that those goals need to be as flexible as possible with the end in mind. The manager is really the one that's going to implement change. They do the logistics. They are always going to be recognizing the need for plan change. They're going to identify the options and all the resources available to implement change. So they're the ones noticing something has changed. Because they're boots on the ground. They're at the bedside. They're on the unit. They're going to anticipate this, and they're going to begin to put the steps and the resources in place to help support that change. So again, we go back to the difference between a leader and a manager, understanding that the leader is going to be at the front end driving it with a vision, and the manager is going to be in the nuts and bolts and the logistics. So when we think about types of change, this is a great list. Plan change is what we're talking about. It's having a systematic process in place to make purposeful change. Interesting with this list, if I were to ask you, how do you think most of nursing has changed? It isn't by planned change. It's actually with the second one, unplanned change or change by drift. We often find ourselves 5-10 years away from where we were, and when we look back at our organizational strategic plan, we realize that where we are is loosely or not at all related to what the original plan was. We need to be more intentional about our plan change and less likely to do accidental change or change by drift. We need to be thoughtful about how we move things along. And I think the more professional nurses are, the more nurses in leadership positions we have, we are becoming more involved in strategic change management, and we're becoming more thoughtful about giving structure to our change and moving along with purpose. Lowen does a great job of reminding us of the reasons we should be changing. We talked in a couple of modules ago about the importance of change, and that can be energizing and create new ideas and keep us dialed into things in our healthcare system. We get stagnant if we're not changing, but we don't create change mindlessly or without meaning. Lewin reminds us that we need good reason. The change needs to be gradual. It's not something that gets done overnight. We need to be planned, and we need to have all the right people at the table. Everybody that's involved as much as possible, stakeholder-wise, needs to be involved. So in that framework of good change, of planned change, Lewin created the theory of phases of planned change, and there were the 3 phases were involved. I'm going to tell you what they are. I will tell you that NCLEX and ATI love this model primarily because it's accurate. When we think about the change agent coming along, sharing a vision, sharing a plan, and getting things moving, unfreezing is the first step. And the unfreezing part is when the change agent convinces the members or the people impacted, the stakeholders, that change needs to happen. And the important element of this is to make sure that the need for change is perceived by everybody affected by the problem. That everybody says, yep, there's a problem, because you have to have everybody willing to move, which is the unfreezing piece, before they get to move. In this unfreezing pace, in this phase, we're also going to gather data and decide on the changes that need to be made. So as you energize people by convincing them that change is necessary, then you begin to gather information and decide, okay, if we've got to change, how are we going to change? The next phase is movement, and this is when the change agent identifies plans and then implements the change that needs to happen. The change agent needs to make sure that the driving force, the reason for change, exceeds the restraining force, exceeds the resistance to change. So that's momentum. You need to be pushing forward, driving the change forward effectively against the stragglers who are struggling, or the organizational barriers that you're going to face, and those are called restraining changes. You want to overcome the resistance, and you want to involve all of the stakeholders. So again, this really is making sure that the momentum and the driving force exceeds the resistance, because you've got to get movement. You can't keep being pulled down by resistance. The next phase is the refreezing phase, and this is when things stabilize, and this can take 3 to 6 months. The change agent needs to stay present. They need, this is going to feel like things are kind of settling down and things get a little bit quiet. It is not uncommon for a change agent who's not well practiced to be there for 30 days and say, yep, everything's fine, call me if you need me. That is too hands-off. They need to be actively involved in supporting the folks through that final stabilization period, because there can be lingering resistance and you can be pulled back into the old way. So be thoughtful about how the change agent can successfully manage that unfreezing stage, the change in movement phase, and then the refreezing phase. And understanding that to be successful, our driving forces need to be greater than our resistance. And that's the piece of it that has to be addressed in the first phase of it. Let's talk about centrality a little bit. We talked about this a couple of modules ago, but I want to bring it up again here just to remind you that the concept of centrality discusses where someone falls in the organizational chart. It talks about communication and how communication is managed in a central location. The key concept for us, especially as new leaders, is many new leaders begin in middle management positions, and they tend to have a broader perspective or a broader view of communication. They are the communication hub. So communication comes from a variety of directions. This next slide gives you the snapshot of the levels of managers. And what I want you to take from this is that middle layer has the compression of communication. So that can lead to burnout, exhaustion, frustration, because you're having communication coming from the bedside nurse leader, staffing, and then into the middle layer, and then senior leadership is talking downward. So that compression of communication, that centrality of information exchange, can be exhausting professionally for leaders, and it can be especially hard on new leaders or managers. So the next topic we're going to talk about just briefly is organizational culture. We touched on this a couple of modules ago as well. This fits in here well because one of those elements of change, one of the things that we have to think about as we try to move things along is really understanding an organization's culture. The definition up here is pretty straightforward. What I think is important for us is when we go into a new environment, when we are trying to figure out, what is the culture of this organization, our best approach to understanding culture is observation. It's going in and looking at what are the dominant values, what are the traditions, what are the beliefs of the organization. You want to ask as little as possible, because what you're going to get is other people's opinions and other people's experiences in that culture. What you want is your own experience, your own insights, and be as objective as you can so that you're not shaded by other people's opinions. So when we think about how do we understand culture, observation is really our first best step. Of course, we're going to have people offering their opinions. Of course, they're going to talk about things around them, but our observation, really focusing on those values, traditions, and beliefs is one of the first steps we need to take. We're going to talk about shared governance for just a moment in reminding you that this is when nurses at every level play a role in the decision that affects nursing activity throughout the system. So the shared governance is a model in decision making. Nurse managers very often struggle in this type of organization of decision making because it removes them from a hierarchical position and puts them in a partnership with the team. That shift of having to be in a committee, sharing power, sharing information, is a tough transition for a lot of managers. It also is tedious. It takes so much more time for decisions to come out of shared governance because it's not an autocratic process. It's more of a democratic decision-making process. And that takes time because you've got multiple opinions, multiple experiences coming together for people to share new ideas and then to make a decision. Just a reminder, participatory management is not the same as shared governance. And our reality in nursing especially is we tend to have more of a participatory management, not an actual shared governance model. Participatory management is more of a allowing other people to share in decision making versus actually making them accountable for the decision making. So when we think about shared governance looks at like a 50-50, shared experience, whereas participatory management can be 90-10, it can be 75-25, it could be 95-5, but people still feel like they're involved in decision making. it's not as structured. So when you hear participatory management, that's not the same as shared governance. And it's important for us to understand that shared governance is an ideal. It's specifically an ideal of our magnet status when we think about magnet recognition and nursing excellence. It's where we want to be. Because of the restraining factors I just mentioned, that can be hard. So be mindful about that. Let's talk about power for a moment. It's not something that ATI even focuses on, but I do think it is a conversation we need to have, because when you think about authority, you think about people who have power. And I want to talk about the concept of legitimate authority. Legitimate authority is required to get things accomplished. We think about authority being the right to command, and it often accompanies a formal position, a management position that you would find on an organizational chart. That would be someone who has legitimate power and legitimate authority. If you are delegating a responsibility, let's say an executive leader goes to a nurse manager and says, I want you to create a policy that eliminates overtime, and let me know in 30 days if you have decreased your overtime by 30%. And the executive says, this is the job that I've given you. This is the responsibility, but then does not allow the person to actually implement the policy, doesn't allow them to enforce change. So they've been given a responsibility, but not the authority and the power that goes with it. It is important that they match, so that if you give someone a responsibility, that they have the power and authority to do that. Very often our first experience with power occurs in a family unit. How we experience the power dynamic in your own family, whether your mom kind of runs things or your dad runs things, or if you have what would be a non-traditional household, maybe you're raised by grandparents or other family or social circles. That really defines our first experience with power. So we want to be thoughtful when we're engaging in power, and as well as when we're delegating it and using it. We want to be very thoughtful about that. A note about power when we think about effective power. Very often, women have not been willing to engage in power and defining their own power within the healthcare system. We are seeing a change in that, but some of that change has not been perceived well. There is a tone of female-dominated leadership structures within healthcare system that really are not perceived well, because women tend to be perceived as aggressive versus assertive. And there's also what they call the queen bee syndrome, which is the experience of females specifically accomplishing success, struggling through challenges, professionally speaking, and getting to the end of that challenge, arriving in a leadership position, and then not being willing to help others succeed, not building a succession plan, but crowding out other people's success and being very egocentric. So the queen bee syndrome is not something that reflects favorably on women, and it is a specifically female-driven term. So I think anyone in a position of power, anyone in a leadership position, needs to be very thoughtful about how we manage that power, and then how we delegate power and authority when we give someone a responsibility. If we don't give them, if we don't give power to someone to actually make changes, what happens when we give them projects that require change is that they're not successful. They simply can't get off start because they don't have the ability to enforce anything. So those things need to go together. This is another chart that looks at the interdependence of response to authority. So there has to be someone who has legitimate authority of a position. The person has to perceive that the power, that person has power, and then based on our own social experience with authority figures, it encourages or elicits a response from us about authority. So with those three drivers, the individual response to authority can vary. I want to just have you take a few moments and really think about what has power been for you. What is your perception of responses to authority? How do you feel about that? Not only just having someone have authority over you, but then how do you feel about being an authority figure? Because sometimes we in the healthcare system, we are nurse leaders, and we do have authority, we do have power, we do have responsibility. We need to be careful in how we administer that to the people around us. Another reminder about communication when we think about organizational structures. One of the elements that come in is the channels of communication, and we talked about this a few modules ago. All these were pretty straightforward. Just another reminder about grapevine communication. Grapevine communication is extremely corrosive to during power changes. When you have someone in a leadership position, grapevine communication, because it is so fast, it cannot be controlled. It can erode the authority or the power of someone in a leadership position, especially if that grapevine communication is negative or contains negative information that's intentionally kind of being pushed throughout an organization. So again, the grapevine communication is unwieldy. It does its own thing. The best way to deal with that grapevine communication is directly, is calling everyone together and sharing the truth of the situation and making sure people understand that information in person. So we kind of talked about the structure of how decisions are made, how centrality influences decisions and the compression of that. Talked a little bit about power. Let's talk about how the nurses, we think about other types of structure. How do we structure care? These are 5 primary models of organizing patient care. You've got total care, functional care, team and modular, primary nursing, and case management. The first 3 are not used as often. And for our purposes, that they are not heavily focused on by ATI. Primary nursing is, and so is case management. So we're gonna just hit those real quick so you have an understanding of what those are. The important takeaway from this slide is to understand that there's no one best method of organizing patient care. What we want to do is organize patient care in the most effective way to provide care for the patient population that you're serving. So how we organize patient care in a long-term care setting is going to look very different than how we organize patient care in a NICU and how we organize patient care in an emergency room. So that's the reason that we still have so many models moving around. The success of a model of care is entirely reliant on the skills and the expertise of the staff, the ability for those nurses to be successful and autonomous in their role, making sure that there's economic resources from the organization to support that model. The acuity of the patients and the complexity of the care they provide also influence the success of the specific types of models of care. Again, there's no perfect model. Lots of them have functionality for different circumstances. So you kind of have to know, what are my goals and how do I want to achieve them, and then use a model that reflects that. We are going to talk about primary nursing because that tends to be one of the more common models. It was originally designed, as it is originally designed, it requires an all registered nursing staff. So there, 20 years ago, we had LPNs that would be, probably actually 10 years ago, we were still using LPNs in acute care settings. That is less and less so now, unless they've been grandfathered in, and then they're normally tracked for specialized skills. The primary nursing model focuses entirely on registered nursing staff. And what this model does is it has registered nurses assume 24-hour responsibility for planning and coordinating the care of the patient. Patients are come in and they're assigned specifically, if you've got 10 nurses assigned on a unit, then those patients are assigned to one of those 10 nurses. And that nurse is responsible for coordinating care, doing their care plan, creating a plan of care, looking at discharge planning for their entire stay. When that nurse is on duty, then they provide one-to-one patient care during that time. If they're not there, then the patient is given to another nurse. But whenever that nurse is there, that nurse is responsible for the physical care of the patient. And then outside of that time, they would need to put a plan in place for coordination of care so that it can be followed when they're not on duty. Disadvantages of that is it really is improperly implemented. You have to have a very skilled nursing team, and you have to be able to coordinate lots of handoff communication, and there has to be an intentional effort for continuity of a patient. Tracking the nurse to patient relationship over 24-hour care when staff are working 8-hour shifts or 12-hour shifts becomes very cumbersome. Many nurses are uncomfortable in the role because they don't have lots of experience and the skills necessary to do that coordination of care, to look at discharge planning, to make sure all of the teaching is set up and available for the patient even when they're not there. Advantages of it, it's a great opportunity for professional growth and development. It is very challenging for nurses to get the whole picture of care for the patients, but it's tough. So be mindful of that primary nursing model if you're part of a unit that does this, that it's heavily reliant on really good communication and that coordination of handoffs from shift to shift to make sure that patient is appropriately monitored by that primary nurse that admitted them, and then at the end will help transition into discharge. Again, it's a great opportunity for professional growth and development, but it is a very cumbersome process and it requires lots of teamwork. The other piece of this was on the models of care was case management, and I'm not going to reiterate that again because we talked about that a few modules ago. I do want to remind you about disease management. When we think about disease management, the goal of disease management is to address chronic illnesses in a way that maximizes efficiency and clinical outcomes. We want to save money specific to a group of patients who require chronic illness care. So in an effort to treat a whole population in a very systematic way, we want to maximize efficiencies, which means we're saving money, we're becoming more effective, and then we're going to improve clinical outcomes. The process is very expensive. It uses significant resources, and the primary goal is population specific. It's treating a population who has cancer, a population who has hypertension. Case management focuses on quality outcomes while containing costs, but they are very much individual driven. Case management is about a case by case situation, a patient by patient situation, whereas disease management focuses on a disease population and it looks at the overall outcomes for improvement within that disease population. Cancer, diabetes, hyperlipidemia, hypertension, COPD, AIDS, stroke, and even otitis media can be under the diseases that are managed with disease management protocols. So do you want to just finesse that point of how different case management is versus disease management and understand that nurses are frequently used as case managers. Disease management programs, we're seeing nurses more involved in that, but not always, essentially nurses. So I want you to kind of know the differences out there. I know this kind of feels like a hodgepodge of information. These are kind of those loose ends that have been touched on. Make sure that if you have questions or you have any concerns about this information, touch base with me. Otherwise, let me know how things are going.